Great. Welcome everyone to Obesity Canada's Hope series. My name is Rachel Atkins and I am the Director of Strategy with the Toronto chapter of Obesity Canada. We have started this Hope series and the goal is that we create community and we can share knowledge with all of you, and that knowledge in turn can create hope as we are all navigating through some challenging times. So I wanted to share with you that we have a really global audience today as we continue to see global participation in these discussions, which is really exciting. We've got folks from Great Britain and Egypt, from France and India, the US, and of course, across all of Canada. Today's topic is coping with self-isolation during the coronavirus, and then also even beyond that. So with that, I would like to introduce our host for today, which is Dr. Arya Sharma, who is a scientific director at Obesity Canada and also a professor of medicine at the University of Alberta here in Canada. With that, over to you, Dr. Sharma.
Well, thanks, Rachel, for the introduction, and welcome everybody. I would say good morning, but I know that it's not morning in a lot of places where you guys are. So welcome to this chat. Just to remind you, Obesity Canada is Canada's national registered charity, and it's dedicated to improving the lives of Canadians. And it does that through obesity research, education, advocacy. Through its work, Obesity Canada educates health professionals, supports researchers, mentors trainees, students, works with policymakers. And all of this is to ensure that people living with obesity in Canada have the same access to treatment, same access to care as people living with other chronic diseases. And a big part of our agenda is to make sure that people living with obesity are treated with respect. So that brings us to today's topic. In a sort of roundabout way, we've been doing the COVID series now because the COVID pandemic has led to, it's a big disruptor. A lot of our lives have changed, and we're still unsure about what the future is going to look like. And this, of course, has an impact on all of us. So for today's conversation, we've invited Dr. Ali Zentner, who's a general internist and diplomat of the American Board of Obesity Medicine. Dr. Zentner has been working in the field of obesity for quite a while. She's got a lot of accomplishments. She was the medical director of a large bariatric program on Vancouver Island. And now she has a large clinic of her own. But apart from that, she's been very, very busy in patient education, peer support, and all of those activities. So Ali, welcome to today's chat. And maybe you can start by telling us a little bit about yourself and how you got into the whole obesity field to start with.
Shout out to Lisa Schaefer. That was very sweet in the chat room. I have actually been in obesity medicine for, I'm embarrassed to say, 20 years. I started off in cardiology fellowship in Calgary, actually, and left cardiology to do prevention medicine. And, obesity was that natural place. I think the long story short of it was I remember my first patient, sort of, if I can, there's probably many, I had sort of diagnosed her at 30-something years of age with type 2 diabetes. And it started a conversation about weight and its role, etc. And like most of my colleagues, I had almost no training in the physiology of obesity. I had no training in the pathophysiology and the disease process and all of that. And so in that self-pursuit, I think as I learned more over the last 20 years, really reshaped my practice and my behavior, and in a very positive way forced me to look at not just the deficit of care that existed in our profession when it came to treating patients, period. Not just treating patients for obesity, but treating patients with obesity for everything else. But it also really forced me, and I think this is a very timely time to talk about this, to talk about things, as a scrappy North End Winnipeg kid, it spoke to my activist nature. But to speak to the frank, bias and discrimination that existed against a population of patients. And I was fascinated by the fact that in medicine, we're trained to recognize patterns. That's particularly in internal medicine, which for those of you who don't know what internal medicine is, think of it like you're a pediatrician for grownups. That's how I describe it. So, and so in internal medicine, you're trained to recognize patterns, and yet where a significant percentage of a population has obesity or may carry extra weight, the pattern of recognition that we as a society were trained to recognize, if you will, came from the distorted view that the media and the schoolyard bully, if you will, had transferred upon us, because we in medicine never were allowed the true, it's interesting. Yesterday I gave a class to first-year residents in internal medicine, and I taught them for the first time about the pathophysiology of appetite, about what happens in their brain and the communication system. And the fact that this was the first time they were hearing this, and the fact that this is a new program for them in 2020 that's just odd. So that's sort of a roundabout.
Yep, and you've accomplished a lot. I mean, in fact, now you have a clinic of your own, and I don't know what's happening in your practice. Are you letting patients in, or is it all virtual medicine? How do you?
So we're letting patients in, just not physically in the front door. So we we transitioned to telehealth on the 9th of March, which is now 3 months ago, and by March 10th, we were seeing 40 patients a day virtually, and have been ever since. We do phone visits for follow-up patients as well as Zoom. We do virtual visits. I will say 6 months ago or even a year ago, if you would have asked me about telehealth, I hated it. I'm the person who, my friends will tell you, I write with a fountain pen and an inkwell. Like, I was old school. And, but what I have found, the beauty of telehealth, it's changed my mind, which is, for physicians, that's amazing. When you accept a mind change, it's incredible. But I think the other thing I loved about it was it has done two things. It's lowered the bar on barrier. Like, patients, first of all, I mean, I worked so hard to ensure that my clinic was this safe space for my patients. And many obesity physicians, that's our mission, is to create a safe space, because we acknowledge that I don't know if I can swear, that we've been douchebags. Medicine has been douchebag, and I'm thinking of a different word, but that's okay. North End, Winnipeg, I have profanity in my veins, but we've been douchebags. And so I work to, from the moment a patient walked in the clinic, for it to be this amazing safe space. And so the challenge was that. Now, with telehealth, I mean,
so let me ask, you're in your clinic right now. Can we take a quick look at your clinic?
I'll show you in a minute. But the coolest thing is I'm in everybody's home. Like, I'm now a guest in your home. And so you automatically feel comfortable. Like, you're no longer a guest in my clinic. That, sure, I can show you around, and the chairs are amazing, and the scale has this beautiful sign and all that stuff. But telehealth, we don't need that anymore, because I was now, like, the barrier in terms of care was gone, because we had lowered it. And I have to work 3 times as hard to be who I am over this method of communication, to make sure that I'm being clear about my message, that make sure we're having a connect. I call them the 4 C's. Like, there's control, there's clarity, there's competence, and there's connection. And those 4 things need to happen in a visit. Well, control is in the patient's hands, which is beautiful. A doctor has to work 3 times as hard to be clear, to make a connection. And as a result, I think competence rises. So, that's something that I think is really interesting. So yeah, it's been 3 months. It's lonely as hell.
So what does your workday look like? Do you sit in front of a computer all day, or what? How does that work?
So Arya's laughing because I 2.5 months ago I bought a treadmill desk because I decided that if I was going to be sitting all day, so I bought a treadmill desk, which means I stand on a treadmill and walk at about 2 miles an hour. You want to hear? So this is where I do telehealth. That's actually a beautiful sign that a patient made me. And then, so like here, so this is our, really there, this is our, that's our scale in our clinic. Yeah, I mean, and I think the goal of the clinic was to create a space where patients felt really safe and comfortable. And, one thing I'll just, this is the sign that people see when they first walk in, was this, partially because I couldn't put up a sign that says, please don't worry, I'm not a bitch. I thought that would probably not be as appropriate, so we put that up instead.
Yeah, very nice.
So those kinds of things no longer, in some ways, are necessary because I now get to be a guest in a patient's home.
So what are you hearing from patients? Because now patients, are at home and they're kind of stuck there, or although things are slowly starting to open again. But for a lot of people, when I look at my patients, for some of my patients, things haven't really changed because they were at home before the epidemic and they're home now. And they were home alone before and they're home alone now. So not really much has changed. But for a lot of people, it's a completely new experience. So what are you hearing?
I think it's variable. I think what I'm fascinated about more is the perception that all patients with obesity are behaving the exact same way. And it's so, like when I hear these questions of, do you have tips to help patients with emotional eating? It's fascinating because maybe I'm, of 20 years, I deal with a population of patients who have struggled with this disease, pandemic or no pandemic. That Tuesday of 2016 was hard, not just this past Tuesday. And, it speaks, it almost, it offends me a little bit, like that, society has painted this massively vulnerable picture of these poor patients in their homes, standing in front of the fridge crying. That's not my patient population. My patient population are a group of badass health warriors who have demanded good care for decades and are waiting for somebody to pick up the phone and answer their call, who have self-managed their disease for far too long, and who are continuing to self-manage now. Yes, are patients and people struggling? Hell, my husband is 5'10" and 160 pounds, the bastard, and he is struggling. So I think everyone is struggling. These are, to coin the latest news term, these are extraordinary times for everyone, because as a species, we're tribal and it's hard and we feel isolated. But I almost feel, and maybe, I look forward to hearing people's opinions, but I feel like my patients are actually doing better than sort of the rest of the population, if you will, not because they're my patients, but partly because my patients are getting treated for their obesity, number one. So there's that. So treatment makes a huge difference. It doesn't matter what disease. I'm sure my colleagues who treat patients with depression, the ones who are seeing their psychiatrist regularly, who are on appropriate medication, who have support, sure, it's a bit harder, but they're doing better than the ones who aren't. The same with MS or, diabetes or hypertension or heart disease, what have you. Any chronic disease that has appropriate scientific treatment, that has continued follow-up, sure, they're doing better. But I also highlight the fact that I have a my patients are resilient as hell. And I think about this more philosophically, that this is a population of people who have been in many ways self-isolated before this happened. Plane rides for many of my patients were off limits, pandemic or no pandemic. Restaurants were not friendly places. Grocery stores were, like no other population of people gets advice in, aisle 4 at the grocery store unsolicited. So it speaks to, unfortunately, this was a population of people who had almost trained for this. And so when I talk with patients, many of them comment about that, and they had from beginning and said, hey, Dr. Z, like, I got this, don't worry. I've been, one of my patients said it beautifully. He said, look, I've been self-isolating for years. I don't know what to tell you. Now everybody else knows what I'm going through, kind of
and
thing.
That's exactly what we talked about in some of the previous, the previous chats. So those of you, who followed this around, there is actually a significant number of my patients and patients, of my colleagues, and we talked about this here, who there's almost a sense of relief sometimes of now kind of being on your home and not having to expose yourself to, what happens outside, whether it's the workplace, whether it's, just being outside, etc. So, people are able to establish the routine. Now it's a new routine, and we'll have to see whether you can keep the routine going once things get back to normal, if they ever get back to normal. But people are finding, things that otherwise struggle with, meal planning, taking time to eat, mindful eating, all those kind of things that we often talk about. A lot of my patients, at least, are finding this a lot easier now that they actually have time. I don't know whether you're seeing something similar.
Yeah, I mean, I will say my practice philosophy has, I have a very, in my practice, we do a lot of medical-based treatments. So I do a lot of pharmacotherapy and a lot of bariatric surgery, which is, that's a whole soapbox that I can happily get on as well. I can see I make no mistake, I hugely see the benefit of, nutrition and exercise, etc., in terms of health, but I am gobsmacked by the fact that no other disease in medicine do patients have to audition for treatment? Do they have to fail lifestyle modification in order to get legitimate physiological help? You know this, there's 5,000 genes linked to obesity, there's 37 different hormones, and the average person is exposed to 600 food cues a day. And we as a species are biologically, evolutionarily primed to store fat tissue, or we die. And yet we're asking patients to white knuckle through hypothalamic and mesolimbic systems that are beyond their control. And we wouldn't tell a person with a rapid heart rate to just calm down. And we don't tell people with schizophrenia to ignore the voices. But we do tell patients who, with obesity to just exercise a little bit more, even though exercise sucks for weight loss, and to do, eat less and watch. And so we in medicine, interestingly, have said that obesity is a disease, but we still behave like obesity is a behavior.
So let me ask you, it almost seems like there's a stigma involved in actually getting treatment for obesity. It's not just, there's a stigma involved in having obesity, of course, but then when you try to reach out to get professional help from your doctor, and your doctor gives you medication or suggests that maybe you need bariatric surgery, there's actually a stigma involved in getting those treatments, because it is often looked at as, you're just taking the easy way out.
Right.
You don't want to do the work.
Right. But there's no sign. So how do I respond to that? So I have a few responses. It depends. So take your pick. Door number one. So it's interesting. You're absolutely right. And the problem with that is that all of us in this room were kids on the schoolyard. So remember, I said that medicine trains us to recognize patterns, but we weren't trained for these patterns. So it's interesting, we started this initiative actually, as you know, through Obesity Canada called the Obesity Project, and through, and it's nofatshame.com, and we're partnering with, of course, Obesity Canada to institute an educational curriculum in every medical school, in every residency program across this country, so that we start early. You know that I've been passionate with mentorships. We've mentored 400 family doctors in Revolution Medical Clinic to expose them to, and we're actually doing virtual mentorships even now. So I have a virtual at 9 o'clock when a doctor from Alberta is calling in and gonna watch me on Zoom practice medicine all day. But to your point, the problem is the stigma doesn't just exist on the part of physicians, but it exists on the part of patients as well. Because patients, I joke that I spend all day trying to convince patients they have a disease, and in the evening, I give talks to doctors trying to convince them that patients have a disease, because we've been exposed to this, it's your fault, just eat less and move more. You know, there's no sign outside BC Cancer that says no pain, no gain. You know, this is gonna suck, but hopefully we'll cure your cancer. Like, there's none of that. And let's be frank, chronic disease treatment should be comfortable in order to be sustainable and effective. And most diets are not comfortable. I've done the legwork, they suck. You know, it's brutal. So I think that's part of the problem. To your point, what I often say to patients is, sure, I can take the route of, you know, it's not easy, it's not the easy way out, blah, blah, blah. That's one possibility. What I often do is two things. One, I explain to patients their disease. So I sit down and I actually have a discussion with them about what's going on in their body and in their brain, like any doctor would do for any disease. You know, you diagnose a patient with high blood pressure, you show them what's going on in their blood vessels. Someone says you have arthritis in your right hip. Hell, they actually put the x-ray up of the hip and show where the issue is. In obesity, first of all, most patients come with the diagnosis, but that's a whole other issue. And don't get me started, you and I share a hate for the body mass index, which I now call the bullshit medical index, but that's a whole issue. But we diagnose a patient with obesity and we say, what are you eating? Which means subtext, this is on you. So what I say to patients is, because they often say, well, that's the easy way out. And I say, you know what? Life is hard and being a patient is brutal. Maybe we try easy. Wouldn't it be nice? Like, buying a lottery ticket is the easy way out. But does that mean you don't buy? Driving to the work is the easy way out. The idea of easy is implied that it's a negative experience, but there are other places in the world where easy is what we want. You know, there's even an easy button with Staples, so to speak. So my argument to patients is, even if we say that this is the easy way out, don't you think you deserve, after years of this crap and of prayer-based therapy, I call it, don't you think you deserve a physiological advantage for something that your evolution is geared to fight against? And the challenge is, medicine by its very nature, I mean, we're all in our homes right now or isolated waiting for a vaccine, which would technically be the easy way out here, people. Like,
yeah. Well, and you know, and having said that, I mean, whether you're taking medication for obesity or whether you're having bariatric surgery for obesity, I mean, that is not the easy way out, because I mean, people who
life
have
is
had
hard,
bariatric
Arya.
surgery,
You know this. Please,
you know,
life's hard. You know what? Being
they
a patient
struggle,
is super hard. Everything's hard. I don't know
okay,
about you.
all right.
Like,
so,
yeah.
So I think, you know, just in the interest of time, we should probably open the floor, because I'm watching the chat room here and there's lots and lots of comments, lots and lots of questions. Some of them are on today's topic, which was isolation, which we really haven't talked about all that much. But I'm sure some of the questions, on that topic, we'll take them. And so, Rachel, you've been keeping an eye on questions. What are you seeing?
Yeah, lots of questions and also lots of great compliments for Dr. Zentner. You obviously have a big fan base, and you're making some really great points that I think certainly resonate with me and many of our audience here today. So I just wanted to remind everyone that there's a couple of ways that you can ask questions. So you can either raise your hand electronically if you click the participant button on the bottom of your screen. You can also raise your hand the old-fashioned way, and we'll get to your question as well. And also, if you prefer, you can add your question into the chat box. So as Dr. Sharma mentioned, the chat box is quite busy. And so my colleague Priti Chawla, who is the Director of Education at Obesity Canada, will be watching the screen for anyone that's raising their hand, and I will be looking through our chat box. So, Priti, I don't really see a hand yet, but I will, head over to you in just a second. Maybe I'll start by asking a question from the chat box. So, the first question that I saw is from Loretta. So she says, Dr. Z, I hope that you take that as a loving term, because I think that's a nice way to refer to you. Dr. Z, you're doing a great job. Can you share some of the advice that you give to your patients to make them the warriors that they are?
Yeah, Ali, that one is
it's a hard question. I think, Loretta, first of all, my patients were born that way. I think what I would probably say to you is almost to highlight. So I have long-term relationships with patients, and my goal is to listen and reflect back. And I think often that question comes from, how do I myself find my warrior? Like, how do I figure me out? First of all, you're already that person. Like, you got up at, I don't know, it's 8:30 here in BC, but you got up, you logged onto a chat line, you're exposing yourself to a bunch of strangers, and you've asked a question of a doctor. You're there. I mean, I think that the idea here is look at your life experience and look at the areas in your life that you excel, because that really speaks to, I think part of the problem with obesity is that we let it define our other relationships, because it does. It's not that we let it define, it just does. And we diminish the fact that, we're good moms and dads, we're good workers, we're good friends, we're good family members, we're great at other things, but we suck at X. And that's not true, right? And the fact that, a warrior means that you're still in it, that you're still looking for answers, that you're still hopeful and still questing and still wanting. The challenge has been not that patients haven't been fighting, it's that medicine hasn't stepped up for you. That's the problem. And I would argue, and I'm a doctor who's telling you it's actually on me. It's I would say my patients have done enough. Man, how many times cumulatively have my patients joined Weight Watchers? Holy crap. Like, Oprah doesn't need the money anymore, please. I know, right. I can see the red.
So Ali, what
I think just one sec. To your point is that I just have a conversation with my patients talking about the idea that they're an expert in their lives and I'm an expert in their disease. And now we're going to partner. And so now they're a warrior with a whole different set of weapons. And that's, I think, where the difference is.
And you just made the point, which, I often, tell myself and our colleagues, is that when we talk about treatments, patients don't fail treatments fail patients.
Right.
So
you're right, because any other disease, we'd say, I'm so sorry, the chemo's not working.
Yeah.
You're a really bad cancer patient.
Yeah.
Your tumor is like, I cannot believe that you grew this tumor. Like, what are you eating that you would have grown this breast cancer? Like, what is that? Like, Oh my God. Even with, it's terrible to say this, but smokers. You don't walk up to a smoker with lung cancer and go, sucks to be you. Should have quit when you had the chance, man.
Yeah. So absolutely, I think how we approach this is absolutely different from how we approach other diseases, and we see that with everything. We see that even with the, we were talking about medication, we were talking about surgery as legitimate treatments for this condition, and yet people have such a hard time accessing those things, right? I mean,
Yeah.
even if you have a private benefit plan, your private benefit plan will pay for your diabetes, they pay for your heart disease, they pay for everything, but then when it comes to obesity, sorry, you're on your own.
And it speaks to an interesting thing, and this is something I am gobsmacked by. This is a room of 100 people. This is an army. Why are we not? I mean, some of us are not Canadian, meaning we're not complacent, because Canadians are very polite and complacent. That's our thing. You know, which is
Mostly,
just
yes.
me. Yes. Well, some of us, no. Yeah. North End, Winnipeg, it's a problem. But I would say we should get scrappy. And why are we not writing our MPs and MLAs and saying, hey, dude, what's the deal? Like, why is it that we're like settling and accepting a status quo that actually no longer applies, you know? It's fascinating with COVID. We've now shine a light on mental health, right? And now mental health is having a moment, thankfully, absolutely. But I am amazed that with COVID, there's even more fat shaming happening. That, there's more discussions about, and I would argue that's not acceptable. So I think that, I guess maybe, and I know Obesity Canada works a lot in advocacy, and I know there's people even in this room who are really passionate about this, but I mean, here's a list. Why is there not more petitions and more, I think there's a benefit. Sometimes we have to get angry in order to exert change.
Well, we've talked about this before, and I think part of why, people living with obesity allowed themselves to be treated as second-class citizens also has to do with the internalized weight bias. That at the end of the day, a lot of patients are blaming themselves for their problem and don't really feel confident that it's their right to speak up. And we really have to change that, because this is nobody's fault. Obesity can happen to anybody at any time. It doesn't matter how fit you were in the past or how healthy you were in the past. Nobody's immune to this. And blaming yourself and then saying, well, I kind of deserve not getting those treatments because I know it's kind of my fault. I mean, that mindset is really what is stopping us from doing advocacy.
But I'm going to actually interrupt you and say, I think even the concept of that patients with obesity have allowed themselves to be treated this way, that's, I mean, even that comment, and I'll openly disagree with you affectionately as a colleague, that comment in itself is dangerous, because that suggests that I don't think we had a choice. I think patients, like it's that whole, well, if you would just stand up and say something, that's not even an option, right? It's like saying the kid on the, I mean, I used to have my mitts thrown in the snow every day in Winnipeg when I was 8 years old by this bully. God love her. She's still, anyways, and she used to throw my mitts in the snow. Does that mean I allowed her to do it every day? So, bullying, we think that bullying takes two people, but bullying is really just a bully. And there's a one person. And so I would argue, I think, however, the responsibility to end that actually rests, yes, on the part of the patient, but also on the part of medicine to really, really look at itself, significant, and to listen. And I say this because, so over the last month, 4 weeks or so, I'm taking a course in my downtime on white privilege, which is interesting because of this whole Black Lives Matter. And I'm looking as well at racism in medicine. And partly because I would argue there's some really interesting parallels about weight bias and where weight bias comes from, and racism, and the body mass index is actually quite racist if you look at some of its historical experiences. And it really has forced me to shut up, which is hard for me to do, and to listen to other people's voices. So instead of me talking about what I think needs to be done to end racism, I want to hear what my role should be to be anti-racist. And I think a similar, I mean, I'm not suggesting that, I think racism and prejudice and bias and all of that, they all have similar roots in the world, and they're all a massive sickness, not just in our society, but in our systems and our healthcare system in particular. But I think we as clinicians, we have an institutional bias that we need to just shut up a little bit and listen to patients about how they want to be treated. And I know that's hard for us because we are the authority, but we're not the authority on a patient's life. And medicine is different now. And the problem is we're still teaching that paternalistic model of 30 or 40 years ago, where patients didn't have any internet and any information. I mean, I remember I graduated medical school 25 years ago, and you didn't hand a patient a study because the words were too big for them to read. Well, that's crap. Like, so those days are gone. So I think I just challenge you to rethink the idea that patients have let themselves be sort of spoken to in that way.
Yeah.
I don't think they had a choice.
Yeah. Well, I look at it as an opportunity because right now in Canada, we've got 7 million people who are more or less living with obesity. I mean, that's a lot of people. That's a lot of voices. Ever since Obesity Canada has become a much more public-facing organization, now we have our patient engagement committee. We've got a lot of followers engaged in Obesity Canada. That's a way of empowerment, and I think that what I'm seeing is that the medical field is ready to start moving. I mean, we've just graduated another 75 doctors who now have specific training in obesity. Now, you could say that's not enough. Every doctor should know about obesity, but we're moving. So I think there's a readiness on the side of the health professionals to actually start thinking about this. We have not been doing a good job, and we need to step up our game. But I also am seeing that there's a lot of patients out there who are now standing up, who are joining organizations, who are not just supporting each other, but are actually taking the next step, which is speaking out. And I think that's going to move the dial, and I can already feel the dial moving. So before we completely run out of time, Rachel, over to you again. Maybe a couple of quick questions, quick answers.
Okay.
Let's do a rapid fire round here.
Well, Priti, how are we doing with individuals raising their hands? We'd love to hear from some people asking questions live. Priti, I think you are on mute. I'm going, okay.
We have Lisa asking a question. Lisa?
All right, let's take it.
Hi, team. Sorry. As far as the isolation component that you guys are talking about, or that kind of got us all in the room today, I think we did kind of drift a little bit away from that topic. I just wondering, I know, Ali, you're a big fan of like quick 3, anything like that. Do you guys have any suggestions right now for kind of facing that isolation component? Because I think as a cohort, we're a group of people that don't necessarily know how to show up for ourselves even outside of isolation. So any thoughts on how we can empower ourselves even more right now in these strange days?
Can I clarify? So when you say isolation, do you mean access to care, or do you mean social isolation?
I think social isolation is more where I'm leaning to.
Okay, so give me a specific example just so I don't take it out of context.
For sure. I feel like for me, I'm missing out on the people and places that I call home and what I consider community, which can feel even more isolating. And I know exercise and diet aren't the solution, but for me, exercise is a really big form of self-care. And my inability to go to the gym and just be around humans is kind of impacting me. So I'm wondering, from your perspective, what kind of successes have you seen with your clients right now? Or do you have any tips and tricks or any ideas how we can create that?
So first of all, I think what I do, just for quick, one, I think understanding that how you're feeling is okay. So like, I think there should be, if you will, I hate to use the term a normalization, but just almost like a standardization that how you feel, the isolation you're feeling, the discomfort, the unsettled, that's actually expected. It's not even just allowed. It's everyone's having it. And that in itself, sometimes knowing that everyone's feeling the way you are is it's a first step towards just taking the anxiety level down just a touch. And then what I would say, and this is something that I talk about with patients, is kind of looking at different things. So I think about it: mind, mouth, eyes, heart. So I pick, and I can only speak to sort of my experience with myself and with my patients, is I pick something. I say to patients, what's something you enjoy to do mind-wise that would allow you to connect? Because now more than ever, there's tons of stuff out there. So for example, if you're someone who always wanted to like see the Guggenheim in Venice, there's a virtual tour going on at this very moment. So taking a class, if you're someone, make a list of the bucket list shit you always wanted to learn about and do that. So I personally, I'm taking a modern art class taught by the docent at the MoMA right now, every Monday. And that creates a community. And what's cool is, and my patients are doing similar things because they would never fly to New York and take, right? So it's almost like it uses the isolation as an advantage. So that's mind. Mouth, having discussions like this. So I suggest to my patients to create community. So if you would normally on Tuesday nights have dinner with your daughter or son or your family or something, do a FaceTime cocktail hour or have dinner with them socially distanced or what have you. So, still don't shut everything down, just use technology to get through it. So that's mouth, so that you have conversations and have conversations that don't involve, when do you think we're going to open back up again? Have you heard the numbers? Those kinds of things. So there's actually some techniques on that. So there's that. For example, play a board game with your family virtually. Your relatives in wherever. And what I would even say to patients is reach out, make a list of the people, oh my God, we haven't seen Holly. She lives in Newfoundland. You know what? We'll have breakfast with her every Tuesday, kind of thing. So that's mind, mouth, eyes. Eyes is like visual stuff. So sure, I think give yourself the opportunity to watch Netflix. There are movies that you always wanted to see, but do something unexpected. So 2 nights ago, I watched the Adam Lambert Queen documentary.
Oh my.
It was fabulous, completely unexpected. Right? Huge Freddie Mercury fan, thought there's no way Queen's going to do well without him. No way. And yet pleasantly surprised. So I just mean unexpectedly, eyes, and then heart is empathy. So whether it's something that brings you joy. You mentioned exercise. So if exercise is something, go for a 15-minute walk, but do it every day. So that's something that focuses you on self-care daily. And it's that one snippet. And I would say have a confined moment of it. So it shouldn't be more than 10 or 15 minutes, whether it's a bubble bath or read a stupid magazine or 10 minutes of reading a book or listening to 3 of your favorite songs every single day, just looking out the window or something. Those are the big ones. I would argue everyone in this room has already heard about engaging in regular routine and getting dressed every morning and all that stuff. Those are the standards that I think, those you've already heard about but I think this takes it to that next level of, mind, mouth, eyes, heart, that I think those are a bit different because we're in this for a long time. This is a long haul and it's no longer a sprint. This is a year. And so what those things do is we don't just want to emerge relatively, it's no longer about surviving this. It's about thriving and finding a nugget at the end, it's almost like if we squeeze hard enough on the coal of this, maybe we'll actually come out of it with a diamond. And I think that's, and so it's about sort of turning that, and this is a room full of huge problem solvers. I mean, you've had to be, you've had to think a bit around things. You've had to navigate a world that hasn't accommodated you. And as a result, it makes you not only resilient, but it makes you quite inventive. And those are skill sets that everybody has. They just need sort of an instruction on how to tap into it.
So thank you, Lisa, for that question, because you've given us the opportunity of actually coming back to the topic of today, which is isolation. And thank you, Ali, for that wonderful summary of all the things that we can possibly be doing at these times. Now, we haven't gotten to, I would say we haven't even gotten to 10% of the questions that are out there, but that's okay. I think we've covered a lot of ground. Just because we want to bring things to a close, maybe your thoughts. You've also been involved with Obesity Canada for a long time now. What do you think is the role that an organization like Obesity Canada should really be playing? What are the things that we should be doing more of? And what if, and I know that you've played a big role in the organization, and what has your experience been?
I think the challenge with Obesity Canada and with obesity in Canada has been that we had to build castles on sand. And so I would argue, I know you can speak to this more than I can, that there's been a lot of foundational work that's had to happen, because the ground has always been very sketchy beneath our feet. And I think when we have to do that, we've learned a lot about what works and what doesn't work. And the challenge with, as you know, with most organizations like this one, or Diabetes Canada or Hypertension Canada, is that sometimes we adhere to sort of a classic model. And as Canadians, we're very good at adhering to sort of classic sort of cookbook models. But I don't know that with obesity, that model is actually as helpful. And I think that's been a learning experience with Obesity Canada, that, what works for Heart and Stroke Canada is probably not applicable here, because already with Heart and Stroke Canada, that's a done deal. Like that's accepted, right? And it's sexy. We don't need to just make obesity sexy. We need to make it accepted first, and then it can be sexy. So there's that piece. So I would say, I think that where Obesity Canada has done, leaps and bounds is in definitely on the research and the academic side, and supporting clinicians and promoting sort of the clinical side of things. And I think if I know that they have definitely started to kind of push the patient side of things, absolutely. But I think its next mission should be more of a build bridging and a dialogue that is more about having those 7 million Canadians at the table, and their voices should actually be louder than ours. Because, and sorry, I will say this, and I think we're learning this, and I think we know this now. Loretta, your cat's adorable. But I think we know this now, is that the government doesn't give a shit what you and I think, Arya. They care what Lisa thinks, and Loretta thinks, and Sandra and Liz and Leah and Dana and Tatiana. They care what they think. So they should. So they should. But so I think that there's a huge opportunity. My wish for Obesity Canada is that we don't just listen, like someone needs to hand that actually needs to be the base of the pyramid and no longer the top kind of thing. And so I think that's where I hope Obesity Canada is headed. The guidelines are coming, knock, knock on wood, whatever. It's like Godot, right? But the guidelines are coming. I think there's lots of projects in play, but what I would propose is every committee that Obesity Canada has should have patients on it.
Yep.
Like a patient voice present.
So as you probably, as you know, or every single committee actually does have patients on it right now.
Except for the clinical, does the
well,
clinical?
they're still looking
I
for
sit
the
on,
patient. That committee has only
okay.
met twice, and so the spot is still open. But every other
I
committee.
think most people don't know that, though. It's interesting.
Well, it's good you bring it up. So we need to
and instead of one patient, I would say, like, if you have one patient and 10 clinicians on a committee, that's not representation.
Well, and then we have, of course, all of the actual patient engagement activities. And Lisa is going to be on one of these talks pretty soon talking about those activities. So thank you again for taking the time out of your practice. And now you can go back to virtual consults. And
yes.
we've gone over time, but
sorry.
As always, it's been a great discussion. Pleasure
Thank
talking
you for having me.
And I think we've covered a lot of ground. So back to you, Rachel, and just for some closing remarks.
Great. Yeah, I'm so inspired. Thank you, Dr. Zentner. And I can tell by the comments that we've had and the questions that it's been a very inspiring conversation for everyone that's involved. So thank you so much. So you guys actually already referred to the clinical practical guidelines, and I wanted to share with you something really exciting that's coming in the next few weeks. Those guidelines are really meant to help empower patients to be able to ask for and to be provided with treatment-based options. So we have really important initiatives like that we're working on in Obesity Canada. And I'd like to remind you that Obesity Canada is a charity. So we really rely on donations from people like you to really help push forward some of these important initiatives. And on that note, I'd also like to mention that, we are coming to a close with respect to our current Hope series, very sadly, because we know we've had so much excitement and so many people involved in these discussions. So we are offering some sponsorship opportunities if people are interested in us continuing with these conversations. So you'll notice, if this is the pre-recorded version of this meeting today, you'll notice that there's a bunch of links underneath the video where you can click on and find out more about those sponsorship opportunities. And the other thing that I would like to ask is, we very much value your feedback. So please click the link. It should also be in your chat box. If you want to click on that, tell us how we did today. Tell us about some other things that you'd like to see us doing in the future. So on that note,
Rachel, before you sign off, can I chime one thing in?
Sure.
I'm so sorry. Hi, everyone. I'm Lisa. I am the chair of the Public Engagement Committee. I would really encourage everyone here, if you could, to go and sign up for the Obesity Canada newsletter. We have some pretty big things coming that will include a community forum. And if I'm following the chat correctly, I think what a lot of people enjoyed today is that this was a really real conversation using real language with very real people. And that is exactly the community that we will be creating online. So we need some beta testers, and I feel like there might be some really interesting humans in this room that might be interested in joining. So if you guys sign up for the newsletter, you're going to find out about the community, and then we will be throwing the doors wide open, and we will be having more Ask Me Anythings, real life conversations. Let's talk about reality stuff. So that's my last bit, and I'll let you go.
Oh, thank you so much, Lisa. That is amazing, because I can tell by the comments in the chat box that people want more and they're ready to take action. That's fantastic. So on that note, I'd like to introduce our topic for next week. So we will have our returning host, Dr. Arya Sharma. He will be joined by Dr. Derek Lee, and they're going to be talking about how is the ongoing pandemic stress driving obesity and other chronic diseases. So with that, thank you everyone for joining us today, and I hope you have a lovely rest of your day. Bye.
Thanks very much. Bye-bye.
Bye. Thank you.